Good morning. Can you hear me? Good morning.
Yeah, good morning.
Oh, I'm like, wait a minute. What did I do now? Lord, it's always something. I get nervous. You gotta talk to me. How are you? How are you?
I'm good, thanks.
Oh, good, good. Okay, so I didn't do half the stuff I was supposed to do, but we're gonna make it through. We're going to make it through. Welcome, everybody. Welcome, welcome. I didn't even send out my little announcements to the people or welcome or anything. Happy Saturday, everybody. Hope you're doing good.
Happy Saturday.
Happy Saturday. Lord knows it has been a week. And a week of just, I don't know. I think part of me really just wants to sleep all day, every day. The fall is my favorite time of the year. So I'm really, I don't understand it. Normally it's like, ooh, we fall, we out here, we doing it. And I'm like, I think it got too cold too soon. Like
That could be.
I just want to lay down. I really just want to lay down. Okay. Okay, I sent everything to everybody. I think we're good. I think we're good. Okay. Let's get this party started. Look at you again. How nice. I felt compelled. I had to add extra pearls. I said, well,
See?
wait a minute. He was fancy. Let me make sure. Let me add my extra pearls here for the occasion. Put on my dress and pearls. Come on, y'all. So, welcome everybody. Welcome, welcome. See, we got folks over here in the club. Hi, Tanika. Hi, Candace. In Clubhouse. Okay, let me stop this rolling banner. I'm getting it together. I'm slowly but surely getting it together. I told you I'm sleepy. I rolled out the bed. It was like 7:45. I said, no, I'm supposed to be up at least by 6:30 so I can get this stuff running. And I've been running ever since. Okay. See all the things that I do to make sure at least y'all can hear me. And then when y'all tell me I can't hear you, it's buzzing. I'll be like, oh my God, what did I do? What did I do? So welcome to episode 48. Look at us. 48 episodes under our belt. I'm so excited. Okay. Welcome to our Saturday morning tea, where we discuss health information, news, education, and certification tips. I'm Clarice Warner, the Girl with the Pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And before I introduce my co host, let me ask you this. Do you know what it takes to be a certified marketable medical coder? Do you? Well, if not, let me share with you some information on a free email course on the 5 steps to become a certified marketable medical coder.
Are you interested in medical coding, but not sure where to start and scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
Now, if you are joining us in Clubhouse, feel free to click the link at the top of the page if you're interested in getting more information about those 5 steps to become a certified marketable medical coder. And if you are joining us via YouTube, Facebook, and LinkedIn, you can check the video description for the link. So joining me today is my friend and family, my co-host, Mr. Jesse, the registered trademark, the coding nurse. So, sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I created the Coding Nurse in 2020, and I help other nurses and other clinicians who have healthcare, clinical healthcare experience transition into the wonderful world of HIM.
And how's that going?
It's coming along slowly but surely.
That's right. Slow and steady wins the race. Slow and steady wins the race. Good morning, Lashanta. Welcome, welcome. Okay, so today we got a lot going on. Today, in this particular episode, we're going to talk about Medicare Advantage and other false claims paper chasers. They paper chasers. So, I'm laughing because you should have saw me and my daughter um, scouring these internet streets for paper chaser references. And of course, Juvenile was the first one. And so there are these paper chasers that got the block on fire. And so the block is hot, especially in these Medicare Advantage streets. But first, let's level set the whole conversation. So I want to give you a little information, um, and this is part of a training that I've used for years for providers on fraud and abuse laws. And it comes directly from the OIG in a document titled "A Roadmap for New Physicians." Now, what I thought I was going to do and what I did do was two different things. So I was trying to get the slide up. Let me see if I can pull that slide up. That gives you the information. Let's see. In the meantime, Mr. Jesse, you can tell us all about your wonderful week. How's that?
So my week was spent in orientation for a new job in CDI, and it's actually, I was pleasantly surprised because you don't find many companies that will spend a whole week training people or orienting people on the culture of the company.
Yes.
I have not had 1 minute of CDI training. It has
Nice.
all been company culture.
That's good. That is really good. And normally you get like a day,
Exactly.
day and a half, maybe. That's the bomb.
4 full days.
Wow. Wow. So did you learn?
Oh yeah, I learned a lot, but I'm just ready to. Well, at this point, I'm ready to start
You
my.
ready to get
So
in
of
there?
course, here, of course, you just can't have trained without some shenanigans. So now the real craziness starts because you're supposed to have your second week in your profile. So mine is empty. So I had to reach out to my manager. So she was like, well, you have to come to a meeting on well, she said come to a meeting. So I said, well, who sent the email? Because I go through my emails, I'm like, I don't have it. So then she says, well, I'll send it to you. Then see if you can log into Epic and 3M. So never told me that you have a whole separate set of credentials to log in for your. I'm like, here's okay, here we go.
Breathe, sir. Breathe, sir. I, breathe, sir. Ah, just let that one misstep go. Cause you'll be taking. I know you taking notes. Like, here we go. Check. Here we go. Let's remain positive. Let's remain positive. Right. LaShawn, do you see me grab my tea? Because I knew it was coming. Okay. I think I'm ready. So let me add this
Okay.
to the stream. All right. So this is what I usually have a discussion about on these fraud and abuse laws, and this is will help kind of level set our conversation. I think when we start talking about these cases that have fell into our lap. So there are really five important fraud and abuse laws that apply to providers. You have the False Claims Act, you have the Anti Kickback Statute, and they have acronyms. False Claims Act is FCA, Anti Kickback Statute is the AKS. You have the Physician Self Referral Law, and that's Stark Law. You have the Exclusion Authorities, and you also have Civil Monetary Penalties Law, or CMPL. Now, all of the government agencies, um, your Department of Health and Human Services, your Office of Inspector General or OIG department. Um, all of these people are charged with enforcing these laws. So that's why you hear in a lot of these cases, they have elevated. Um, some of them stay at the state level, but oftentimes things are discovered and they elevate to the federal level. And so it's important that those providers know what's going on with these laws because, of course, it's not just important to know them and to follow them because it's the right thing to do, but there's also some heat if you violate them. So there are civil penalties that could occur, civil fines that could occur, exclusion from federal healthcare programs. They could even lose their license from their state. So it's really important that our providers are aware of all of the things that happen. So I told you there are five of them. Today, I'm just going to focus on these two. I thought about adding exclusion, and I might talk a little bit about that, but let's start with these two and see where we go. So, um, Mr. Jesse, do you have anything to add? Questions, whatever?
No.
You just jump in whenever. So, the False Claims Act is found at 31 um, United States Code sections 3729 through 3733. That's where you'll find all the legalese relating to that. And this rule protects the federal government. It protects the government from being overcharged um, on services or for being sold. The quote they have is shoddy goods. So, shoddy goods and services. So, it's illegal to submit claims for payment to Medicare or Medicaid that you know or should know. And that's the other piece. You either know it or you should know that are false or fraudulent. If you file these false claims, it results or may result up to in fines up to 3 times the program's loss. So whatever the claim is, whatever the program would paid you, you can get a fine up to 3 times of that amount, plus at a minimum $11,000 per claim filed. So that's why these numbers are in the millions and billions when you hear, the reports of what has happened with XYZ provider. That's why those because they're not just saying, oh, here's one claim, you know, you're good. They've looked at hundreds of claims, maybe dozens of claims, but at least hundreds of claims um, to determine what the penalty should be. So it's 3 times the amount claimed plus at a minimum $11,000. I think it can go up to 22,000. So from 11,000 to 22,000 per claim. Again, each instance of an item or service billed to Medicare or Medicaid counts as a claim. So again, you can see how those numbers can quickly add up. And then if the claim results in other things like a kickback, or if it's a violation of Stark, or any other thing, then there's also kind of civil False Claims Act liability as well. So they can also hit that same claim can be responsible for other things if it violates other laws. Now, under civil false claims, no specific intent to defraud is required. So they don't care about the intent. um, and in that case, it could very well be an accident, if you will. But again, it's the knowing part, and they define knowing to include not only actual knowledge, but also instances in which the person acted in deliberate ignorance or reckless disregard of the truth or falsity of the information. So you see that spectrum is quite large. You didn't know about it, but you should have known. So if you were ignorant about it, or you were reckless and disregarded what the information was, or the truth or falsity of the information. Also, the Civil Federal or False Claims Act contains a whistleblower provision. And this whistleblower provision allows a private individual to file a lawsuit on behalf of the United States and entitles that whistleblower to a percentage of any recoveries. Mr. Jesse, we've talked about this a lot. Whistleblowers could be current or ex-business partners, hospital or office staff, patients, or even competitors. Now, we're talking on this about civil False Claims Act. There's also a criminal False Claims Act. That's in 18 United States Code Section 287. And then criminal penalties for submitting false claims include imprisonment and criminal fines. So that's when you see like folks are going to prison for submitting false healthcare claims. The OIG can also impose administrative civil monetary penalties, which we'll talk about in a minute, for false claims or fraudulent claims. So you see, there's a whole machine that operates behind all of when you click that button to send that claim to Medicare and Medicaid. That's why it's important that you make sure, or somebody in your staff, if you're a provider, you want to make sure that things are correct. Because again, at the bottom of those claims, or with every claim on every claim form, you're certifying to the accurateness and completeness of this claim. Even if you don't sign that claim individually on paper like we used to way back in the day, when you push that button and you send that claim over electronically, you have certified that the information on that claim is correct. Next, let's talk a little bit about the Civil Monetary Penalties Law. And this is found at the 42 United States Code Section 1320A through 7A. And it tells you, again, that the OIG may get in their feelings and seek additional civil monetary penalties and sometimes exclusion for a whole bunch of stuff that they see are violations. And they can seek different amounts depending on what it is, or how they choose to assess the violation that they think has occurred. But the penalties are capped, and they range from $10,000 to $50,000 per violation. Some examples: if a person presents a claim that the person knows or should know is for an item or service that was not provided as claimed, or is false or fraudulent. Remember that definition? We just talked about that. That's considered a false claim. Presenting a claim that a person knows or should know is for an item or service for which payment may not be made. If they violate the anti-kickback statute, violating Medicare assignment provisions, violating Medicare provider agreements, providing false or misleading information expected to influence a decision to discharge, failing to provide an adequate medical screening examinations for patients who present to a hospital emergency department with an emergency medical condition or in labor, that's EMTALA, and making false statements or misrepresentation on applications or contracts to participate in federal health care programs. So there's a lot going on in the machine that is occurring once those claims have been submitted. Now, the compliance professional in me is compelled to talk a little bit about compliance. So one thing is that, and a lot of these I've learned, it's been my experience, recently. Now, the hospital programs and some larger physician programs um, and provider programs understand the value of compliance. Some not so much, and I'm curious as to why. And maybe I will set up a Q&A sometime with some providers and find out, do you have a compliance plan, and why or why not? So compliance plans actually help avoid these fraudulent activities and help to make sure that providers are submitting true and accurate claims. Um, there are 7 components that are that should happen for a compliance program. Now, most of these compliance programs are voluntary. However, with the passage of the Patient Protection and Affordable Care Act, providers who treat Medicare and Medicaid beneficiaries will be required to establish compliance programs. So keep that in mind. So some of the things that are part, or the 7 components that are part of a compliance program, is to conduct internal monitoring and auditing. So you should be looking at, or somebody internally should be looking at, most places actually put an additional set of eyes and have an external monitor or auditor, but somebody should be making sure things are right and checking. That's all part of that whole revenue cycle, making sure that, if there are denials, they're looking to see what happened, double checking that claims are going out the door appropriately, etc. So there should be some sort of internal monitoring and auditing. They should also implement compliance and practice standards. So there should be some standards, SOPs going on in that practice. They should designate a compliance officer or a compliance contact, someone who has the compliance knowledge and training to assist, who also knows the practice and the practices of the practice, to be able to assist and be the mouthpiece when and if the folks come a knocking. There should be appropriate training and education. So when things are found that are missteps, or when things are found that are in error, someone should say, okay, let's make sure that the people who are involved know what's going on and make the appropriate corrections. They should respond appropriately to detected offenses and develop corrective action plans. So yes, when they come to you and say, we have found XYZ, or you, according to our reports, our PEPA reports, our I can't think of the other one off the top of my head. The other billing report that comes out that I can't think of it. But anyway, there's another automated report that the government uses to say, okay, you're
Is it CERT?
Yes, thank you.
Okay.
I said jump in when you need to. CERT.
Okay.
That tells you, hey, things are awry or things are off. When you get information related to that, you also had like the probe and target, or probe and educate information that may come to you if you are a provider that provide services on one of their target areas. So they'll let you know and they'll tell you. And so it's up to you to make sure that you're providing the information to those who need to know, and then developing the appropriate corrective action plans as a result. You also should develop open lines of communication with employees. Oftentimes people will set up some sort of hotline or something where people can be anonymous, because those who are actually working right there on the front line know way more than those who are removed several levels. So it's important that people feel that they can tell someone, hey, I think this might be an error, and or this may be going on. Can somebody take a look? Can somebody make sure that we're doing the right thing, et cetera, without feeling that they're going to lose their position, or that they will then be cast out, or whatever. So and they should be able to be anonymous if they choose to. They also need to enforce disciplinary standards through the well publicized guidelines. So those are the things that these practices should have as far as compliance programs to protect them for um, for when they're submitting these claims. Go ahead.
You know, I appreciate you, your compliance and you laying this out. This crap they're not doing none of this in the real world. This is why it's the way it is. Every place I've worked had a compliance office. Every place I worked had a compliance officer. Every place I worked had all the steps. They had a toll-free number, but they didn't do any of it.
And that's
Because
unfortunate because I the places I've worked, we did. We had a wonderful compliance program where every year, like we sat down and we did risk assessments to determine what the areas of risk were. We put together monitoring plans and this was, and I worked at the system level. I was system director. So we worked at the system level and we pushed that down to all of our facilities in all of our regions, that they were responsible to make sure that somebody pulled some of these records. And then we took all of this data. So we knew where we stood in relationship to that. So, we looked at and this is when the work plan came out annually versus the monthly thing. So I'm dating myself, but we would take a look at the work plan. Well, what are they looking at? Well, what's happening? And then we would go through that, we would research that, and we would craft our own kind of monitoring based on that every year. And so we had some tried and true things that we monitored a lot, because if they didn't reach the baseline, if they didn't reach our goals of at least 95%, 98% in some areas, then we kept monitoring until they got there. And then ultimately there were penalties assessed to not only that region, but those penalties went to folks' pockets, i.e. bonuses, the top person, the CEO of that particular region, etc. So we had a well crafted, flowing compliance program, and so that's why I'm so passionate about it. And so it baffles me that people don't understand and take it as serious as it is. Also, our hotline, we monitored the hotline. Once we got calls or information, we followed up. That's the purpose of having a hotline, where people to tell you something. And if they're telling you something, then you're going and following up and checking to see and whatever. And you have the appropriate interviews with folks to verify. And sometimes things will be like, oh, that was just an error, or they misunderstood or whatever. And trust me, our hotline ran the gamut. Most of our hotline calls, however, were HR related. But, we things that were HR related, we pushed over to HR to handle. And then, if we needed to be part of it, then we would be part of the conversation if necessary. But yeah, this just blatant disregard. I mean, and so folks wonder why the government is out here on fire. This is why. And maybe they know that people have a blatant disregard for compliance programs. But then if they get hit with more stringent rules and violations, they can't play that game, because then all their money goes away.
Right. But the thing is, nothing ever happens to them, because, okay, you have to pay back $10 million to a company who's already made 50. So what?
No. And if it escalates, I can't think of the term.
But no. But I'm telling you, no. I'm telling you what I'm seeing right now. I worked for a company. I told them 3 years ago they were committing fraud. They got accused in 2021, last November. The DOJ filed charges. What they have done, all they do is they get rid of people quietly. They resign. They don't get fired. They resign, and then they did a total revamp. They got a new logo, and they're rehiring all the same people. They're replacing their positions. That has happened everywhere I've worked. No company has ever gone out of business that I know that had to pay back money to the government.
And I'm not suggesting that. There are oh, what is it? It's gonna drive me
No,
crazy.
what I'm suggesting is I think they should go to jail, and I think that'll stop it.
And they probably should. You're absolutely right. There is I can't think of the name of it, but so if the OIG or Department of Justice finds you guilty of fraud, you have the penalties, but then you're also placed on this list, and on this list increases the scrutiny that you go through with them. So it's not just you pay the money and it goes away. Again, if it escalates to this list, so then they are forcing you, they are checking you every month. The OIG comes in, or they send people to check your stuff on whatever it is that they found you um, guilty of every month, and making sure that you have these components in your compliance plan. All of that happens, and you're on this list for years. I know of several large organizations who have been on the list and have lived through it, and it's painful. You think doing this work internally is a lot, or taxing, or oftentimes you hear
Right,
about compliance programs where it's not revenue generating, but it's revenue
right,
saving.
right,
And so
right,
they don't want to do it. But then on the back end, when you're forced to do it, because again, they come in and they're checking you on a regular basis.
right. I hear that, but the same people who have driven it into the ground are not there to clean it up. It's new people who have to come in and clean it up. They're not there.
That's true. But ultimately the organization is responsible, and or the provider is responsible,
They done gone on and got another job
and doing the
because
same thing to somebody else.
exactly they go from place to place. This is why it's the way it is. They leave one company, go to another company. They chase codes. They drive up revenue. They make the money. Then when they get busted, they move around.
So again, folks need to do their due diligence, research, find out who are the people that have been involved in these cases. Run them checks when you're employed, so you know what you're looking at, and whether or not this person is employable for you, because you don't want them same problems.
But how are they going to find out if if this coding manager was part of some bull crap at another company? That's like word of mouth. That's like, now the coders would know because it's a small world and people talk. But in HR, they won't know until the person's already hired. And you sit up in, or you sit up in a meeting. Oh, here's our new member. Blah blah blah. And, wait a minute, she was a so and so. It's too late then.
So again, why are those not part of the conversations, or the at the interview, or why are those? I mean, somebody is not doing their due diligence.
Oh, a whole lot of people aren't. That's why it's the way it is. I'm telling you, it is a mess out here in with Medicare Advantage. A mess.
Wow. Yeah.
And they inflate they inflate the profit, they get the money, and they run. And okay, the company has a corporate integrity agreement for 5 years. Okay, well, those people been gone. They're going someplace else wreaking havoc. And they move around. I've seen it. They move around. And the same mess they did it at company A, they're doing at company B. And they bring their friends.
Bless their heart. So all of that to say, and level set the conversation about this stuff happening at Cigna. Did you want to take this?
No, you can go.
Really?
Because I mean, the article, like they kind of, well, kind of, the article made it very plain what they were doing. They only had nurse practitioners going there just to say it was a face to face, period, and forgot all about meat, forgot all about medical necessity, forgot all about clinical validation. That was not even anywhere in anybody's purview.
Mm.
It's crazy.
And
Who?
it's a whistleblower. It's a key term.
But that's how it always is.
Yeah.
Because I mean, now I really understand. Now I finally get it. Now I understand why CMS wants to move to a what do they call it, value based payment system, because it's so easy to catch people. It's so much easier to catch people with ICD-10 CM versus CPT, because CPT you got to do a lot of reading. You got to read the operative report. Well, was it the left toe or was it the right toe? You got to get real specific. But ICD-10 CM, you can see it a mile away. Okay, well, this wasn't even addressed. This doesn't even meet medical necessity. I ain't even got to look far. Or if there's no clinical validation, this is just sitting here, you didn't do anything to address this issue during this encounter, you can't get credit for it. It's easy to get, to catch fraud with ICD-10 CM.
Yeah, and so if you're joining us on YouTube, LinkedIn, and Facebook, if you look in the description, I think I actually posted the articles or the information on this case. So the United States filed civil fraud lawsuit against Cigna for artificially inflating its Medicare Advantage payments. And so the crazy part is, y'all know where the money resides. There's a lot of money in Medicare Advantage, and folks are coming after it left and right. Um, and clearly not doing the right thing. So in this case, the government alleges that the diagnosis codes that were reported were based solely on forms that were completed by vendors that were retained and paid by Cigna to, and the purpose of these vendors were to conduct these in-home assessments of their plan members. These providers were typically nurse practitioners, and as soon as I saw that, I was like, oh my God, I could see the AMA. I could see them coming, more shots fired, but that's neither here nor there. Who conducted these home visits. And they did not perform or order testing or imaging that would have been necessary to reliably diagnose the serious complex conditions reported, and were prohibited by Cigna from providing any treatment during the home visit for the medical conditions that they supposedly found. The diagnoses at issue were not supported by the information documented on the form completed by the vendor, and were not reported to Cigna by any other healthcare provider who saw the patient during the year in which the home visit occurred. Nevertheless, Cigna submitted these diagnoses to the government to claim increased payments, and falsely certified on an annual basis that its diagnosis data submissions were, quote, accurate, complete, and truthful, end quote. And yeah, they just got in trouble. Yeah, they just got in trouble. So it's a lot. Oh my God. Did they put the vendor's name out here?
I didn't, when I read it, I didn't see it.
Oh, they call them the vendor HCPs.
No, the vendor healthcare professionals. That's that's Cigna. Because this is, the home visits were typically conducted by nurse practitioners and on occasion by other non-physician healthcare providers such as registered nurses and physician's assistants, the vendor HCPs.
Yeah, that's what they call them, or calling them in the complaint.
Right,
Nothing
but there
different.
that's referring to Cigna's. That's
The
this
vendors that
360
Cigna
form.
contracted out
Right.
to. Oh, but here's the other piece here. Cigna had its coding teams identify diagnosis codes that corresponded to the recorded medical conditions, and then submitted those to CMS for risk adjustment payment purposes. What's that? That's Cigna all day.
Oh, of course, because they were the ones that told those people what codes to put. Because I'm telling you, like, what I've worked with, I don't know how many, I don't know how experienced these nurse practitioners were on this team, but a lot of them, in my experience, they'll document whatever you tell them to.
Mm.
So it's not hard to get them to document something.
It says that the vendors spent limited time with the patients and did not conduct a comprehensive physical exam. When they were completing those assessments and recording those diagnoses, they relied on the patient's own self-assessment and their responses to various basic screening questions. They did not have access to the patient's full medical history and typically did not obtain or review relevant records from the patient's primary care physician in advance of the visit. So they were all in the blind and just taking whatever. It says in tens of thousands of instances, Cigna submitted diagnosis codes that represent serious complex medical conditions that were based only on the home visits conducted by the vendors, ACPs, required specific testing or imaging to be reliably diagnosed, which was not performed, were not supported by the information documented on the 360 form completed by the vendor, and were not reported by any other healthcare provider who saw the plan member during the year in which the home visit occurred. I don't understand.
I understand.
They just came
It's
in and zoop, 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 send them out
th-
and go and get them.
that I understand exactly because one of my last employer wanted to do something similar.
Mm,
And what they do is they find these vague HCCs that you can kind of like that are part of like excludes to. You can code this and code that. But if you're a coder, you code to the highest level of specificity. So you shouldn't have dubious because you shouldn't have too many excludes two codes together because you should have specificity to know exactly what a condition is. So they do that because they're trying to do is just increase the RAF score. Period.
correct. That's all this
So
was.
they find all these vague things and try to add on to it. But if you're doing your due diligence, you should have very specified codes, especially when you're being examined by a licensed healthcare provider and
But
you have access to medical records.
they didn't look at those medical records and or did they examine
Right.
them?
Right, because all they did was told them what to do and they did it.
Oh my God. And so
Because
they mentioned some of the conditions: chronic kidney disease, congestive heart failure, rheumatoid arthritis, and diabetes with renal complication.
but
It's
I'm
crazy.
telling you, like there's another company, I'm telling you, in about another year or so, you're gonna hear about them on the news. My former employer, I ain't gonna say their name because I'll wait. Because this is what I'm telling you, they all do it. And then when you say something, when you tell them it's not right, you can't do it, then you become the problem.
Yeah. Good morning, Vicky. You're right, Lashanta. Oh my God. This is bananas. This is bananas. And then they wonder why. Right, you're right. These poor patients. You it's just a mess.
Oh, it is.
It's just a whole hot mess.
Because all they see are dollars. Period.
So in some of these other circles that I follow, most of them are attorneys and some providers, um, some compliance people sprinkle here and there, and other health information professionals. Um, but usually, the conversation speaks to trying to tear apart um, the rule or the law or the government's um, what they have set out as this is what we're using as our parameter to determine that an error has occurred. This is what we're using to develop our methodology for reviewing these records or auditing auditing these records, etc. And I feel some kind of way about that as well because you want my money. you gonna have to play by my rules to get my money. Government, I got the money. You want my money? Let me. Here are the rules that you need to play. There may be some gray in the rules, and of course, there's always gray in everything. And so those small gray items, possibly debatable. But every little thing that now I do because you didn't get caught and not following my rules, and now I want my money back plus some. Now it's a problem. But you didn't do you signed XYZ contract to be part of getting my money. You said, hey, you saw the opportunity, and it was like, okay, well, let me jump on in here and take these and do Medicare Advantage and set up all of the parameters, get these HCC coders in here and all of the things that you were supposedly signed up to do to ensure that this process runs smoothly and as that document said, accurate, complete, and truthful. But when you called out and exposed allegedly, now it's a problem. Now it's a problem with the rules. Now it's a problem with, well, why are you doing this? And you didn't say that. Again, reading is fundamental. Folks not reading or doing their due diligence when they jump into these contracts or jump into these pair arrangements. I'm at a loss.
Well, you're at a loss because you're thinking about it in a totally different way than what they're thinking about it. They're thinking about a cash grab. They're thinking, well, if we can increase the risk adjustment factor and we can increase the revenue by XYZ, then when it's time for my annual bonus, I can say, look at the increase in revenue under my watch. And then then they in turn get a larger bonus. And it's all about them.
So do they go back and be like, well, look at what we lost under your watch?
No, because by that time the person is gone. By the time it happens, they don't say, well, you got to pay this money back. You're gone, and that's it.
I don't know. Hey, Candace.
Hello. I just wanted to chime in. So, I currently work for the payer side, and I'll give you kind of like a hint too of how. Well, I work for the payer and the facility side, but whatever. So, anyway, so basically, from the facility side, if you think about it, when you get audited from the payer side, it's only a small amount of cases, when you compare it to your the bigger picture, right? So for instance, if you have I don't know, say 50,000 cases for the year, however, say Signal or Blue Cross or Medicare or whatever, they'll come in and say, okay, we want 20% of this criteria. Well, even if the facility have to pay back 20%, that still doesn't touch the masses, right? So then the next year they'll go back and they'll be more cognizant. Okay, we can't do this, we can't do that. Then they'll be more compliant. And then the following year, they'll probably have maybe new management or whatever, or maybe new interpretations. And then they'll do it again. But if you're not consistent with being non-compliant, then it's not a red flag from the payer side, right? Okay. So that's also the thought process of how these facilities are operated, because I'm more on the inpatient side, but whenever I'm auditing the coders, like, it's things that I would never do because I do have that payer knowledge. However, on the facility side, it's a lot of interpretation, especially working with CDI and how they say or feel they could clinically validate, quote unquote, and all of this and that. But in essence, that's how they think,
Well, I appreciate you.
But
information. Go ahead.
I do appreciate that, Candace, but at the same time, there's really not a lot of gray area. People make gray area, but it's really not.
Oh, and you're correct, because they interpretate it to their benefit. Because I've seen cases where they won't do something because of the same reasons they would do it on another case. And then it's person to person, it's manager to manager, because like the facility that I work for, it's a multi hospital system. So you have, and it's not really centralized, however, they try to be, but if I speak with a CDI manager at one facility, they would never do the same thing as another CDI director at another one. So it's big on interpretation. But again, say if they pull a sepsis audit, right? And so say they pull 20%, and of that 20%, maybe 10% is non-compliant. Well, that's not a red flag to the payer, and then the facility still wins because, again, they don't look grossly non-compliant. And it's not the right way to think, but it is. So whenever I turn hats to the payer side, the same things that they probably would let out the door, I know I would deny.
Right.
You
And
know,
also,
so
and that same situation, sepsis. Now, Candace, you and I both know, and even you, Clarice, as coding, you know that sepsis, the guidelines are very clear. I mean, so I don't understand. Like, either you have an associated acute organ dysfunction or you don't, or you either you have shock or you don't. And if you don't, you query the provider. I don't understand why it's so much gray area when people just don't follow the guidelines and do the appropriate querying in-house to avoid all this.
I'll tell you, because every facility has to operate on a different sepsis criteria. So, for instance, New York, they only have to go with sepsis 2, which is two clinical indicators and an associated infection. However, certain companies like I don't know, like UHC, the payer side, they go by SOFA 3. So they can only, audit hospitals that go by that criteria because of, contractually, they'll say, okay, patient sepsis have to meet SOFA 3. So the things that I'll probably deny from those UHC hospitals, I would pass for New York because they only have to have 2 clinical indicators. And I'm telling you, they're very vague. So it could be elevated white blood count and tachycardia with pneumonia. And that physician can compliantly say this patient is septic. They don't have to have in organ dysfunction nor shock nor any of that. However, where they get denied is length of stay. So if a physician says patient sepsis, but they only stay for 2 days, that's literally not. We all know that's not septic, but it will be compliant based upon their sepsis criteria. So that's where you can be gray in essence, right? But like acute respiratory failure, UHC is more stringent than Humana. Humana is more stringent than Blue Cross. It's just they know, okay, if they want this, like New York hospitals can never have UHCS to be their provider because they will lose a lot of money in comparison to just straight Medicare or any Medicaid place or payers or whatnot. So that's where it's gray. Yeah.
But
And they
you know,
don't and
but
they don't
that
split hairs either. So when they say sepsis, they lump everything in one. They're not breaking those buckets down when they report back the findings, or do they?
Yes, they do. So for instance, so if I am auditing, so if I'm working on the payer side, every claim that I get is gonna be a different payer. So if it's 1Q, it'll say UHC, it'll say Humana, it'll say, so I have my own criteria based on the payer
Okay.
to audit. So I
Okay.
could never use the same criteria for a Humana claim that I would use for UHC. And then also too, some hospitals will allow you to, some payers will allow you to quote unquote up code or whatever. So if for instance they put, or the coder puts pneumonia and that's not valid, but say acute respiratory failure is valid, but the coder didn't code it for UHC, I have to deny the claim, go back to the hospital, and then just put in acute respiratory failure. It'll be the same payment. But like Humana, they will allow you to say, okay, well, even though pneumonia is not valid, well, they have another MCC, so therefore I can just let the claim go. So every payer has their different protocol and parameter because, like, I feel UHC just kind of wants the facility to fight for their money, whereas other payers they don't care about that back and forth. So it's different. I know I'm not really an outpatient or home health or that type of auditor, but I know on the inpatient side, another big one is COVID. UHC is more stringent. Metabolic encephalopathy, they're more stringent. So we can deny a lot more claims than I can for other payers.
But I think that is a big part of the problem because It also is like that in outpatient, especially with Medicare, when you have these different Medicare administrative contractors. Regionally, there are differences. I don't understand how, as important as healthcare is in this country and how big this country is, why there's not a standard across the board. And it can be, it's just that somebody doesn't want to enforce it. Because, for instance, like there shouldn't be all these different protocols. Like one company shouldn't be able to have sepsis SOFA 3 and somebody have SOFA 2. It should be a standard that everybody follows. Then that way everybody's on the same page. And it's just like that with Medicare. That's why Medicare is the way it is. That's why you have some things can make it through a MAC in Texas, but it won't make it through a MAC in Wyoming. It's craziness.
Well,
And I think
and
it's all go ahead.
Medicaid, that's how Medicaid is. Medicaid is different state to state. The states make up their own.
But I'm saying, but I don't think they should. I think there should be a standard, especially since it's all coming from the same payment source, which is us.
But I think it goes back down to the basic level of care. So I feel that a lot of physicians, especially when IPPS came about, they were turned off with being clinicians, right? So because of the payment. And I think that that's why they are kind of, in my opinion, I feel that a lot of, even though we have guidelines and laws and all that stuff, I do feel that it's always going to be in favor of the provider. Um, some people kind of take it a little bit too far, but I think that when it boils down to it, I don't think they want the rules to be so stringent to where providers won't want to provide care anymore. And I think that is why, they allow more than what they should, or, this state might have more leniency than another, or because they will, I think, ultimately they will feel as if, okay, I'm providing all of this care, which they really don't. But even if they feel that way, they don't want the providers to be turned off with providing adequate care. And I do think that that goes to why we don't have a socialist, healthcare system too. Um, because I've heard a lot of physicians, because even working at a company called Acuity, the thought process was I audited coding, they audited clinically the physicians, and so we had to sit on the phone with physicians 8 hours a day. And so that was a lot of that feedback where it's like, okay, I'm killing myself, taking time away from my family, doing this and that, and I'm getting minimal pay. And so that's why hospitalists came aboard and all of this and that, because they don't see the financial gain in it, with respect to all of the things that they have to give up.
And you hit it on the head. That is the, even though Medicare, Medicaid have a lot of numbers or a lot of beneficiaries, and so the numbers are particularly there. The payment that they receive, and then the work that is required for them, and not just the work in seeing those patients, but the extra work. So the quality work, the documenting all of those additional components. It's not balancing out, and so you have a lot of providers that in some cases don't even see Medicare and Medicaid patients, or they put a cap on how many Medicare and Medicaid patients that they actually see.
But that is part of the problem with our healthcare system anyway, because we have a lot of people, and we just need to be honest. We have a lot of doctors and nurses who are only in it for the money, period. And if you're a bag chaser, I don't know. I have not met a good bag chaser that's a good doctor or nurse. I've never worked with one, because your focus is the money. You don't care. You want to do the bare minimum and sometimes less than that, because it's all about the money. You sitting there calculating your money.
Or you're going to do things fraudulently.
Right.
Are you trying to find
So I think
workarounds and stuff?
you have other countries who have socialized medicine, and they have providers that they're not short of staff. They don't have people aren't going lacking. Actually, they have better health outcomes than we do. So there's a whole paradigm shift that needs to happen, period. And whenever the incentive is money, it's always going to be wrong.
I agree. This was great. This was great. Thank you so much, Candace, for your bringing
Definitely.
your
No
lens
problem.
and perspective, your expertise and experience to the conversation. I appreciate that. Thank you so much. I learned something in that. I think I had another real quick. There was another false claims on home health billing from Florida that happened this week as well.
Florida
Um,
is a mess.
the Carter Healthcare LLC was an Oklahoma or is an Oklahoma based for profit home health provider. Um, and so collectively, well, they're in Florida and I guess in Oklahoma. And their president, Stanley Carter, and chief operating officer, Bradley Carter, have agreed to pay 7.175 million to resolve allegations that they violated False Claims Act by billing the Medicare program for medically unnecessary therapy provided to patients in Florida. Um, yeah. Again, they wanted to the OIG wanted to just make sure folks understand that, especially to home health providers, and I think we talked about this briefly. Like some of those rules have changed, and a lot of folks are oblivious to them. And home health is like the low lying fruit um, of the auditing world or community because it's a mess. I don't even know. Well, that's a whole other conversation. Like I don't even
But
know why they continue to allow that. They should just be stripping everybody. Um, they allow the group, the CEO and owner allowed to, or the partners allowed to be excluded for 5 years and then pay the money back. Oh, that's what it's a corporate integrity agreement. So they when once you are put over into a corporate integrity agreement, your life is not the same for however long you are in that. And so it requires that the company have to put together all of those compliance things um, at that point at that time. So it, I mean, I guess it gets to the point where it has to have to get there. This all came about once again from a whistleblower who were therapists that were employed by Carter Healthcare. They put their name out here too. Um, yeah. So both of them will receive 1.3 million as a share of their settlement. So yeah, folks, it's this game is out here. It's real. This block is hot. This enforcement block is hot, hot.
but this is exactly why home health is moving to capitated payments instead of fee for service, because once again, it's a lot easier to catch fraud with ICD 10 CM than it is with CPT. So that's why they're moving. And they started already. And next year, I think they do something that it moves into something else because they started PDGM in January of 2020.
Uh-huh.
So they're moving. Something else has happened. Oh, Oasis E starts
Uh-huh.
January 1st. And then there's part of Oasis that's going to be factored into their payments.
Well, let's see. Lashanta, you asked me a question. Where is it? Here. In your compliance experience, how many audits per quarter is a good number for physicians? Um, Typically we look at, so we do a whole risk assessment or on the providers, especially if we're working with a group or a system. We're doing kind of a quick overview to see, where they lie um in their, and I'm speaking on from an E&M perspective. So we'll look and see where they lie. We see, what their patient mix kind of looks like, the severity of the patients that they're seeing, et cetera, et cetera. And then we'll start with a baseline of 20 to 10 to 20 records because it doesn't take all day to recognize rain or sunshine. You can easily determine or see patterns in folks' documentation. They don't venture off far based on their documentation, especially if they're doing a lot of copy, cut, and pasting, which drives me through the roof. But so you can quickly see, okay, this is the pattern that they're doing. This is what you see, and so you have enough information and data to then um, formulate your findings and provide the appropriate education in that regard. So that's usually what we do. Like 10, 20.
I wanted to
Depending
ask.
I'm sorry, Mr. Jesse.
No,
And
go ahead,
depending
go
on
ahead.
the client, because sometimes where their benchmark is. So if they want their people to be at 95 or 98%, if you're only doing 10, and they'd be like, well, that's not fair, la la la. And so you may increase the numbers a little bit just for that. But it really doesn't take all of that. Usually 10 records will get you what you need. Go ahead, Mr. Jeff.
I wanted to ask Candace a question about her experience with sepsis and also to some extent COVID, because some people have had sepsis from COVID. Well, they've had sepsis and COVID. But I wanted to ask particularly her um, experience with acute respiratory distress syndrome, because if some patients present with acute respiratory failure, that is, according to the coding clinic, acute respiratory distress syndrome, acute respiratory failure is part of acute respiratory distress syndrome, so it would be considered present on admission. Candace, have you had any experience where you've denied acute respiratory distress syndrome as not being present on admission?
No, because
Okay.
of the coding clinic. Yeah.
Okay.
Yeah. The only time that we would quote unquote deny it is if we can visibly see that COVID or acute respiratory distress syndrome or a decline in the patient's respiratory, system in essence happened after admission. But if they
Okay.
all came in on present, yeah, then we have to keep it.
One more question, Candace. Do you have a clinical background? Are you a nurse and a coder?
I'm not. But I started nursing school in the fall. So
Okay.
because I see that I feel in about 10 years, coders and HIM will be obsolete. I foresee in the inpatient world, just because CDI is taking over.
So do you feel
Okay.
it's necessary to have that clinical nursing? You want the nursing license to continue on in the
HIM world, yeah. And I'll probably do like PRN nursing just to get the physiology aspect down pat. But as far as for my field, and yeah, I foresee that. And then also no. So when I graduated in HIM, it's funny because initially it was in the College of Business.
Mhm.
I'm sorry, College of Business, College of Science.
Mhm.
But about a semester into it, we changed into the College of Nursing, and I think that that's what gives me a one up off of a lot of just straight, HIM professionals in the inpatient world because it's really, really clinical.
Well, that's interesting. They moved their program that way.
Mm-hmm. It's extremely clinical. And then also when I was doing my quote unquote internships, okay, I saw physicians rounding in the HIM department for them to also get an idea of what it takes to be an adequate, documenter, because that's what it boils down to. Because physicians, they will definitely push back on query and like answering the queries or answering them sufficiently, I guess.
Mhm.
And so now
Right.
with the newer physicians, it seems as though they actually have to take a coding class within their residency for them to understand why it's so important.
What state are you in?
I'm in Michigan, but I graduated from the University of Louisiana,
Okay.
Lafayette. So, but I definitely foresee it being, because my friend, she actually graduated in healthcare administration and she was working for Blue Cross in the denials, and they laid all of the non-clinicians off and they
Wow.
hired all nurses. And even working like on the payer side, we have like if I'm looking at a claim or whatnot, and there's something that's heavily documented, however, it doesn't meet clinical criteria. Before I say yay or nay, I have to refer it out to a clinician for them to audit it on the clinical side.
That's interesting.
Mhm.
That's interesting. I see your brain twirling, sir.
Look, I get it. It's business. I get it. But I'm telling you, I think Kahima should step in because honestly, Candace, with your experience, I mean, trust me, I understand why you're going to get your RN. I totally get it. But nobody could hold a candle to you because you have skin in the game. You have time and you know the rules and regulations. That means something.
And your
There's no
vantage point, you see it from both. You have the experience on both sides, so you
Mhm.
have
But I'm gonna tell you, like in the hospitals, they don't care about coders for real. They don't. They don't. Like I have, like there's this program that we kind of made up. It's called collaborative escalation with my hospital. So my job is to kind of meet in the middle between the coder and the nurse, right? And so it's so many claims that we as coders would query. If I was a coder, I would query, but the nurses will come back and say no because even though it's not consistently documented, they were treated with this, they had a lab of this, they wouldn't
so,
have did this or that or blah blah blah, and then I'll try to fight it, but the medical director will step in and say no, if it comes back as a denial, I can uphold this denial. And that's the thought process.
wow.
because you are supposed to because the thing is when you are a coder, when you work in the capacity of HIM, you are working in a capacity of a coder. You have to work within the HIM code of ethics, not the nursing code of ethics.
Right.
So if you have to query in the presence of unclear documentation, you have to query in the presence of undocumented of unclear documentation. And this whole the whole medication just drives me crazy because everybody wants to code from a medication list and you really cannot, and it gets people in because people do it all the time, trust me, I know, but
Yeah,
it's
because what if you're
just
taking medications for something? They're your medications for something else that.
and and I think that if they want to put that much emphasis on the medication list, then the provider should list what the medication, what diagnosis the medication is for. Then it's
Yeah.
cut and dry because then it's
Then it's
documented.
exactly. Oh, that's interesting.
Because as a nurse, you can't, even legally as a nurse, you cannot say what a medication is for because that is the diagnosis, and no nurse, RN, LPN can diagnose. That's beyond your scope of practice.
Or unless Candace, you're going to be a nurse practitioner.
I don't know. I don't know. We'll see. But I definitely do think that that coding has definitely changed. I've only been in the game for 9 years, but I've audited like seven, I guess, of those nine, and then I always kept like a contract on the side or something to not lose that aspect. But yeah, in essence, it's just. But every facility is different, like you have some facilities that are very stringent, like the facility that I work at, coders can't query if a nurse is on the case, period. Whereas other facilities, if it's a coding query, then the coders could query based on documentation. But if it's clinical, then of course they have to discuss it with the nurse. But at the facility that I work in, is a very clinical driven facility. And it could have coding clinics, it could have everything. Like the biggest thing right now is the poisoning guidelines. So if the nurse feels as if yes, this patient was on crack, yes, this patient had a heart attack, yes, the doctor linked it, but presentation clinically doesn't show a poisonous effect, right?
Right.
And so yeah, and then another one is like the complication guideline where we all know if a patient has a complication, and that patient came prior to, and then that hospital now boom has a complication due to a prior surgery at that facility. Oh, they tried their best to get away from that.
Oh,
They'll
definitely.
figure it out.
Right.
Yeah, they'll
They
figure
can
that
work
one out.
miracles.
Yeah, they'll work some. Like I had one where the actual query advised that the device was due to the abdominal wound infection, and that nurse went to the medical director and they said, "Oh, that infection was already there from the abdomen wound and it's seeded into the device. So it's not, or they'll do this. They'll say sepsis due to the abdominal wound and the device. And we have a coding clinic that says if sepsis is due to two different etiologies, we can choose either one.
Right.
So they'll go with the sepsis. Yes, they'll still add the complication, but it'll be a C and won't affect anything because it's not the reason for admission. It's a lot of caveats and interpretations, and I think I think it just feeds down to outpatient, inpatient, whatever. Like if they look at a guideline and they feel that their specific scenario can kind of divvy away from it, they will try.
That is amazing. Candace, we're going to have you back.
Anytime.
Definitely.
We're going to have you just a whole session. Look, I'll send you the link. We'll bring you on the camera and everything. We just going to have you back.
Anytime.
Just to have a powwow, because I want to, and we're running out of way over time, but I just want to pick your brain and piggyback on your thoughts as far as inpatient coders and how obsolete that they're looking, and then even talk about your experience and the decision that you made with going into nursing. That is interesting to me. Yeah, so we definitely gonna have to have you back. Cool.
Sure.
Mr. Jesse, you have any closing thoughts?
No.
No.
Somebody has their hand up. You want to bring them up?
Who? Oh, come on.
Did you? I'll invite to speak. Okay.
Hi, everyone. Thanks for a great discussion. I learned a lot. I learned a lot, so hope to join publicly.
You're breaking up, or is it me? Hold on. Maybe I need to know. Okay. Did you hear her?
I think it looks like she's muted.
Did you hear her? Because she broke up on my
end. It was choppy, but now she's muted.
Okay. Drea, could you repeat? Let us mute and make sure, because it might be us.
Yeah, let me.
Can you hear me now?
Yes.
Yeah.
Okay. Oh, hi, everyone. I know it's late, so I won't hold you. I just wanted to publicly thank you all. I learned a lot on the call, and I hope we can continue to have the discussion. I don't want to jump down the rabbit hole, but I know with the nursing industry, we lost a lot of nurses going into payer roles and becoming coders and all of that. And so I know that's put a stress on the healthcare system. And so I think it would be an interesting discussion to continue to discuss kind of what direction inpatient coding is going.
Ooh, I like agree. That perspective. Mm-hmm. So that'd be cool. Look, we're gonna do a whole panel. Drea, I'm gonna reach out to you as well. Maybe we just do a whole panel and just have at it.
Definitely. Because it's changing, and look, why not be ahead of the curve? Why not have some little morsels to make the right decision to position yourself to take advantage of it.
And it's all about, and you're absolutely correct. It's all about making sure that you are positioning yourself in your career, however you see fit. So taking those appropriate paths and taking the necessary steps to achieve those areas so that you can land where you want to land. That's what's up. That is what's up. Oh, this was very interesting today. Look, when we started out with the whole the paper chasers and changed into a different type of chasing. Yep. Chasing these careers.
That's right. Drea, I will say this. I will say that I foresee it's going to be a paradigm shift, in my opinion. I foresee that it's going to be very scarce in the patient care and more in the administration, only because I'll say this, that when I look at the salaries, so if you look at the salaries, of course, right now throughout the whole pandemic and everything, nurses are winning, doctors are winning, and because of all of the money that they're paying out. But when things are going to stabilize, what happens in the coding world is that 95% of your jobs are at home, right? So you don't have to go to any hospital, any facility. And the way that they're hiring is through outsources, right? So I say contract, but it's really not in essence, right? So you're a W-2 worker and everything. But what I've learned is a lot of people are getting 2 jobs, 3 jobs, and they're making 200K plus. And you can get all of your work done in 8 hours if you are really good and efficient, right?
Mm-hmm.
So because everything is productivity based on the inpatient side. So for instance, the average, case load is like 20 cases a day. Now, you in like on a Monday, you can get 3 jobs done probably in 8 hours, 10 hours, depending upon how your lifestyle is. And then you can still, like I said, bring home that 200K because these jobs don't care if you have 2 jobs. These jobs don't care. They don't care. They just want the productivity.
Right.
So that's why I see a major shift. But when it comes down to the payment, if I go and try to get a coding job right now, I might get probably 35 to 38, depending upon the state and the facility, right? And so if I'm doing that and I can get my work done in 4 hours and I'm done for the rest of the day, well, a lot more people are more interested in that than, working 12 hours. You get what I'm saying? So I
Yes.
think it's going to be a major shift.
I agree. I'm experiencing that in my own department with case managers. I'm competing with insurance companies where they can work from home. They don't get pulled into staffing and all of those things. But I want to touch on Jesse's point. I do know when I'm speaking to a nurse who is new to coding and understanding that realm, because I do see sometimes the payers will hire nurses that are straight off the floor that fundamentally don't understand how our healthcare payer system works. And so, as opposed to getting on the phone with someone like Candace, who can really give me fundamental, solid, information. So, I do agree with Jesse's point that, just because someone has an RN, that doesn't mean that, their ability to meet the needs of the organization is any better. It's truly the skill level and the experience. But nurses going into those roles, it's just making the hospitals harder to staff because, I mean, yeah, who can compete with that? So I think it's an interesting, discussion, but I would just encourage you all that, again, just because you got the RN, it doesn't mean that you're better than the coder, because it's been my personal experience that hasn't always held true. It's the person's experience level and engagement with the role. So I could tell you guys are excited about what you do and speak with passion, and everyone just doesn't have that.
We talked about that last week, the passion.
And a lot of people have moved away. I've been in healthcare for a minute. When I've got in healthcare, everything was a team. Now everything has become so individual. I do this and you do that.
Silo.
There's nothing wrong with having RNs and coders and CDIs work together, because then everybody is better. Everybody learns. Everybody elevates. Patient care elevates. Reimbursement is more stabilized. I mean, it's a win-win when you think of it collaboratively. And I think that nursing has kind of got away from that when they moved away from team nursing and started this primary nursing model, especially with this whole magnet status. It just really caused a mindset shift in nurses, and I think healthcare, period.
And I totally agree, but I think it's about parameters too. I think it's about, I want my department to shine more than your department. And I think that's why it'll never be that way, because we're held to different standards. Like, even with like, I'm not, I've never worked patient care, so I don't know about that model, but I know like on the administration side, like coders, we're not even held to a reimbursement stance, right? Because of course, ethically, we have to think about, proper documentation, etc. However, CDI, their main focus is optimization. So we could never work together because coders, we don't care about that. You know what I mean? So it would have to be literally an organizational change and just a mindset change. But then again, to touch on Andrea's point, as far as nurses not having the coding skill set, there are so many, even with Jesse's, business, as far as trying to cross-reference the clinicians on into the coding world and things of that nature. I foresee a human doing that. Like I foresee them doing that. Like whatever it gets to a point to where there, is an abundance of coders nurses wanting to go into that. I foresee that they come up with a new program to cross-reference the two, because I have my CDIP and it's heavily relied upon how to, build a CDI program and all of that, and really limits it to coding. They have a few coding things on there, but it's not anything, when you get in the real world. But I will say a lot of facilities don't care. Like they will, the code, the nurse will code, okay, they'll put some codes on there. It's wrong. So the coder will fix it. But then we have to still heavily rely on them for the heavy hitters, like the MCC, CCs, things like that. So if they say it's a go or not a go, it's not a go. And it still goes to the nurse's favor at the end of the day, because they're the ones that's going to optimize that case.
Now that is really sad because I just know for me, I have been teaching nurses for 2 years, and it's not, you cannot do CDI effectively. You can't do CDI at all if you don't know coding, if you don't know reimbursement methodology, because how are you calling yourself a CDI if you can't even tell the difference between an MCC and a CC? If you can't determine what's going to increase the DRG the most, if you don't know that when you look in this PCS book, that when you get to the fourth character, anything in purple is a non-OR DRG, and it's going to increase the MSDRG. Those are things that you have to know. And I know that it takes me a lot of work to get nurses where they need to be. Some of them don't make it in 8 weeks, and some of them do. And the ones that do, like, because you got to put that time in. You have to repeat those guidelines, and it's just constant. It's constant scenarios, constant. Well, because one word can change everything. Right. Inpatient, outpatient, acute versus chronic changes everything, and you have to know how you would adapt to that on the fly.
That's right. I see you, Drea. Yes, be here for work-life balance and entrepreneurship all day. Look, I see a whole bunch of nurse practitioners in the future. Candace, I don't care what you say. Running the show. Oh, this was great. Yeah, look, y'all got me turning because I could see the whole little panel. Look, we're going to put this together. I'm going to reach out. What you think, Mr. Jesse? You ready? I don't hear you. Why are you muted?
I mean,
Okay.
I totally agree. And it's important. And I think that it is important for especially people of color,
Yes.
Black folks, to get yourself in a position where you can capitalize, because very, very rarely are we privy to the precipice of anything great.
Exactly. And who is telling you this? Who is telling you this information? They taking your money in these learning institutions and so on and so forth. But who is telling you the real?
That's right.
It to you. So
let me tell you. That is so true. Like on a personal level, my dad just underwent a double lung transplant back in August. And when I looked at his post discharge, paperwork, it's so like I will say he had a great healthcare system. I will say, because he's still here. But when it comes down to documentation, it sucks. It completely sucks. So therefore, he had to make me his power of attorney so that I can get the proper documentation. But there are so many patients that don't know. You know what I mean? Like they diagnose them with things. You know how in the coding guidelines it'll say if you have a suspected condition, it could be, documented as confirmed if it's on the last discharge, or the last progress note. Well, they diagnosed him with so many things that they had suspected earlier on that they never said. And I'm like, this is insane, because this will impact people's, life insurance that they don't have.
Yes.
All these different things. But yet the facilities literally got paid for those CCs, MCCs, because he had pulmonary fibrosis, but he doesn't have a lot of chronic conditions. So I know that on that stage, it was COPD or whatever.
Mhm.
So that would have been a CC for that, admission, or you know what I mean? Like that's how my mind starts to think. But it's like, why isn't this rectified? You know what I mean? Like they know that's not what he has, and they keep on adding it, and so it's just so many patients who don't know, and it's sad. It's really sad.
Yep. And I'm making those corrections. And then ultimately the patient suffers in the long run. The patient suffers. This was a lot. But it was great. It was great.
Yep.
All right. Well, we are at 10:30. We done went 30 minutes over, Lord. But this was great. I love it. I
It was
enjoyed this
good.
conversation. This was really, really good. And yes, I am going to reach out to both Candace and Drea. We're going to put together some kind of panel, and so we can have some more dialogue and discussion around health information and nursing and all those things, and even consider some various paths that folks who are interested in our profession can kind of travel and again be prepared for, and of course be proactive versus reactive, being proactive in choosing the path that works best for them. So again, thank you everybody for joining the Saturday morning tea. Was the tea spilled today?
Definitely.
Like there was all kinds of tea everywhere. So if this information was valuable for you, please help us to share this message with others by liking the video, commenting, sharing the video, and subscribing to the channel. You can also check out, and our channel is the Professional Reimbursement Network. I think we got our handle. It's at PRN Coding EDU. That's a quick way to find us as well out there on YouTube. You can also check out the Coding Nurse channel on YouTube. And last but certainly not least, to my Clubhouse folks, you can click on the greenhouse to join in on the fun in our club, and you will get notified of our live broadcast, which usually occurs on Saturday morning at 9 a.m. Eastern Standard Time. Also, there is a wealth of knowledge, as you all see in the room on Clubhouse. Make sure you network with each other, follow each other. You may have questions. I know we all are very passionate about what it is that we do and the information that we provide, and really just here to help advance each other in the information and the knowledge. So make sure you guys follow each other. Any other closing thoughts, Mr. Jesse, that you may have?
No, I really enjoyed today's room, and I enjoyed everybody's input and feedback.
Yes. Thank you all. This was great information. See, it turned from one teaching moment to the other.
Mm-hmm.
So thank you all again for joining. And remember, be safe, be kind, and don't wish for it. Work for it. Until next time, take care. Have a great weekend. And prayerfully, we'll see each other next week.
There you
All
go.
righty.
Bye-bye, everybody.
Bye-bye.